This lecture is over the immune system, which is the first lecture in the materials for exam 2. When we think about the immune system, I want you to think about it as both innate and adaptive. So, for one thing, the word innate means that you are born with it, all right? It does not mean that it is non-specific, even though it is non-specific, but innate means you were born with it. And after we go through innate, then we will talk about adaptive. So the innate defense system is non-specific. It goes after everything and everybody, or blocks everything and everybody, right? But the good thing about this is it is very quick and is activated right off the bat. So there's 2 lines of defense with this innate system, and both of them are non-specific, right? So if we think about skin and the mucosa, that's the first line of defense, and those are barriers, right? But it's barriers to everything, good and bad, and that's what takes us back to this non-specific piece. The second line of defense is against everything again. It is non-specific, and these include antimicrobial proteins and phagocytes. So the first line of defense is barriers, and that second line of defense are our internal defenses. If we have phagocytes that attack, fever, NK cells, those are natural killer cells, antimicrobial proteins, and inflammation. All of that is internal defenses, and it is non-specific. It's going to attack a virus the same way it's going to attack bacteria, the same way it could attack something that's good for us, all right? Of these, inflammation is the most important mechanism, and we'll talk a little more about that later. The second type of defense system is specific, and it's adaptive, right? It is adaptive. And so this includes what's called humoral immunity and cellular immunity, and that's the B, respectively, the B cells and the T cells. So this type of defense has memory, and it is specific. It is antigen specific, and it's antigen mediated. So whatever is presented on the outside of a cell, that is what is going to control or dictate what occurs with this defense system. It does work with the other system, your innate system, but it's going to recognize specific foreign substances, and it's going to immobilize, neutralize, and or destroy these substances. So you need to put an and/or there, right? Okay. So let's go back to this innate, the non-specific, the first lines of defense. We've already talked about the fact that your skin and your mucous membranes are barriers. So when you think about skin and mucous membranes, both of them have in common that they have layers of cells, and you shed these cells. You also have sebum. Remember, we talked about sebum when we talked about skin, that inhibits the growth of bacteria and fungus. The pH is low, it's 3.5, but remember what happens when sebum builds up, that it can actually be a place where you can actually attract bacteria and fungus. And mucus has the job of trapping particles, whether it's microbes or dust or pollutants, whatever it is, it's going to trap it, and it's going to contain it so that it can then be managed after that. So the next type of barrier is lacrimal apparatus. So very simply, those are your tears, right? Tears are part of this defense. Saliva, vaginal secretions, the actual flow of urine is a barrier. Defecation and vomiting are barriers. If you ingest something that is not agreeing with you, then you know you will either vomit it up or defecate it out, or both. And then you have these very acidic gastric juices that destroy bacteria and their toxins that may come with them. So along with these barriers, we also have chemical and cellular defenses. We have proteins that are called antimicrobial proteins. We have three: interferon, complement, and transferins. We have natural killer cells, and then we have phagocytes: neutrophils, dendritic cells, macrophages, both wandering and fixed, and eosinophils. And in this image, you can see some of these chemical and cellular defenses at work. Also, you can see them attacking the bacteria. So we'll go into each one of these. These purple cells are macrophages, the green cells are neutrophils, and the blue cells are dendritic cells, and the smaller black cells are cytokines and chemokines. Right? So this line up here indicates that there is a skin barrier, and clearly there is a wound here. All right, so let's look at interferons. Interferons can be produced by multiple different types of cells: lymphocytes, macrophages, and fibroblasts. And these interferons have the job of interfering with the translation of viral proteins. So let's just talk about viruses for just a minute. When you look at this image up here of this virus, I want you to look at it and notice how simple it is. Yes, this is a simplified diagram, but I want you to notice that it is rather simple. On the inside, you see its nucleic acid, but on the outside, you see this six-sided figure, and that is made up of protein. So that is a protein coat. So very simply, a virus has proteins and nucleic acids. It might have a few carbohydrates as well, maybe some lipids. But if you'll notice, there are no organelles. It doesn't make its own energy. So my question to you is, and it's rhetorical, I don't want you to respond, but I want you to think about, how can a virus be alive? Is a virus actually alive? It doesn't make ATP. How does it function? So if a virus isn't really alive, then how do you kill something that's not alive? A virus is a nasty little critter because it actually uses your cells, uses your DNA, and uses your ATP to make more viruses. And that's why they're so difficult to manage. So in this image, what you're seeing is that there is a virus that enters a cell. When the virus enters the cell, the nucleic acid leaves the virus body, and it actually then goes into or triggers the nucleus of the cell. When it triggers the DNA in the nucleus of the cell, it actually is turning on the genes for interferon. And I want you to think about the word interferon. It interferes, right? It's an interferon. So when the nucleic acid of the virus is made available within your cell, it turns on the interferon genes. And when that happens, interferon is made. It goes through the whole process of transcription, as you can see right here within the cell, and goes through translation. And so here are the interferon molecules that are made. They then leave the host cell, the first host cell, and then they bind to the host cell 2. And when that happens, it turns on the antiviral proteins so that they are produced. And so here is the production of the antiviral protein. And so when the virus tries to infect host cell 2, then these antiviral proteins are going to block that viral reproduction that you saw over here in the host cell 1. It is a fascinating process, right? So it interferes with the translation of viral proteins. Also, interferons have the job of activating macrophages and natural killer cells. So we know that macrophages are big eaters, and natural killer cells are a component of your innate immune system, and they can then attack what else is left out there of the viruses. So both of these are some of the culprits. So I just put a negative spin on it when we're talking about someone who is having a organ transplant, because they can be part of the rejection, but they both also, now here's the positive spin, are going to be part of the rejection of tumors, so that you actually know that there is a tumor and they can kill it if it's caught early enough for some of them, and other virally infected cells. All right, but as you can see, this is not specific against any specific virus, right? It is going after all viruses. It doesn't matter what it is. So complement is another type of innate non-specific response that is part of the chemical and cellular defense. There are 3 ways that complement work, right? And we're going to look at those 3 ways. But what we're looking at is that we have plasma proteins that are made, and they promote the destruction of the microbes and inflammation. And how they do this is absolutely fascinating. Is they all of these complement proteins come together. So if you look at it, there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, or 12 complement proteins right here. They come together and they make a pore in the microbe, and the pore will then take on water. The pore allows for the taking on of water, and the cell will explode. So there's 3 ways that complement works. The first is the classical pathway, where you have an antigen on the outside of a cell, you develop antibodies, and that can activate complement. Then there's one called the MB-lectin pathway, where you have lectin that binds to the pathogen, and then you have an alternative pathway. Regardless of the way of the 3 possible pathways, okay, so don't get too hung up on this, it activates complement. And when complement is activated, 3 things occur. You get more cells that cause inflammation, which is good. You have the opsonization of a pathogen. All that means is that you've tagged a pathogen so that it can be attacked by a phagocyte. And then you also have the killing of the pathogen. And all of those can be due to complement. Another part of this second line of defense, this chemical and cellular defense that we've been talking about, is phagocytes. And so these are cells that are going to eat the invaders. And the first one is the macrophage. As we've already talked about, they're the big eaters. They're what are considered to be the chief phagocyte. There are free ones that look for microbes to eat, and they search for cellular debris. And then there are those that are fixed. We have some in the brain and some in the liver, as well as other places, and they are sit-and-waiters. They sit in a specific space and wait until something comes by, and then they'll eat. Microglia are good examples, and Kupffer cells in the liver are also other examples. Neutrophils are another type of phagocytic cell. They only become phagocytic when they encounter infectious material. Eosinophils are considered to be weakly phagocytic, and they are against parasites. Remember what we talked about. If you have a high eosinophil count, then there could be a parasite infection. And mast cells have the job of just binding to and ingesting a wide range of bacteria. So in order to mobilize a phagocyte, it's going to take some chemical cues. So in this very first image, you can see that we have a capillary. It has phagocytic cells that are the yellow cells on the inside. It also has red blood vessels. Red blood cells. So it's within the tissue. Here's skin. A pin pierces the skin. There are bacteria on the pin that has pierced the skin. So we have macrophages on the outside of the capillary, and we have other phagocytic cells that are on the inside. These look like to me to be perhaps neutrophils. So chemical signals are going to be released. These are these little blue dots by the macrophages and the mast cells that are in there. And this allows the capillaries to widen. So you see the widening of the capillaries. And we've talked about this before. When you have a vessel that widens, it actually increases the pore size that's in there, and it increases the space between each one of the cells. So what escapes from the capillaries when this widening occurs is there are blood clotting elements, and that's what you can see in these bigger purple dots. And it moves from the blood to the site, and so you're going to get clotting because of this. Also, the macrophage and other cells are going to release chemokines, right? And chemokines are substances that attract more cells to a space. So we're talking about chemotaxis again. So different types of cells are going to release chemokines, and they're going to attract more phagocytes. So you can see here that we have the neutrophils that are leaving the capillary to go to the site. So now we have neutrophils and macrophages that are eating the pathogens, and the tissue will begin to heal. That's a very simple example of phagocyte mobilization. Okay, so fever is also a great way to fight an invader. So when we have macrophages that start this counterattack, it actually triggers a substance called interleukin-1 to go to the brain, and it raises the body temperature. Now we're going to talk about interleukin-1 a little bit more further in. So when interleukin-1 goes to the brain, this temperature in the body is going to increase because of pyrogens. So these pyrogens, pyro is Latin for fire, and gen means to begin, right? Genesis. These chemicals secreted by leukocytes and macrophages are exposed to the bacteria and other foreign substances, whatever the invaders are. So the good thing is that if you have a high fever, it can denature some enzymes, and it could be denaturing enzymes that belong to the bacteria. The bad thing is it could be denaturing your enzymes. So when we talk about having a high fever and how bad that can be and it needs to be lowered, well, you don't want to do damage to yourself. Now, a moderate fever can be beneficial to all because your liver and spleen will hold in zinc. It sequesters it, zinc and iron. And when that happens, you get an increased metabolic rate, and it speeds up tissue repair. So when we're talking about this, remember, we're always talking about an adult who is in homeostasis. Always talking about an adult in homeostasis. Please do not think that you should allow your child to maintain with a fever. That needs to be discussed with your physician. All right, so let's look at these diagrams. Here you have some invader, a pyrogenic activator, that has allowed for the pyrogens to be produced. So you have the producing cells, and they produce and release these pyrogens, these endogenous pyrogens, which then go to some form of a mediator, which then produces a fever, right? So you can do the endogenous pyrogen, that's the interior, or you can just have a pyrogen activator, and that makes a fever. Another way to look at it is you've been infected by some exogenous pyrogen, so that's the pyrogen activator, whether it's bacteria or a virus or an endotoxin, whatever it is, that interacts with a phagocytic cell. That phagocytic cell produces lymphokines, and those lymphokines then allow for more production of phagocytic cell. Don't tell me what type of feedback loop this is. Please say positive. All right. The phagocytic cells will trigger interleukin-1. Interleukin-1 triggers in the hypothalamus prostaglandin substances to be made. And so again, the more prostaglandins are made, the more you're going to make. Again, another positive feedback loop. And what this does is elevate a person's temperature. Okay, so let's talk about what inflammation does. So inflammation is telling your body as a whole that there is a problem. And so it is a release of chemical alarms. So when you have inflammation, you have vasodilation, and you have an increased permeability of the blood vessels. Okay, so if you think about the fact that you, let's just use a fire ant bite. So when at the site of the fire ant sting that you've had, or bite, you have localized inflammation. So how do you get that? Well, the capillaries in that area will dilate. And when you have dilation of those capillaries, not only is it allowing cells out, but it's also allowing additional fluid out. And that's why you get the swelling, okay? So you have the emigration, remember that's leaving a place of phagocytes, and that's going to get rid of the pathogens and debris, and that should prevent the spread of chemicals or pathogens. But along with those phagocytes coming out, you're also going to have fluid that leaves. Now, I talked about a fire ant bite as an example, but let's talk about somebody that has perhaps a whole body inflammatory response. It's systemic inflammation. That means there might be swelling all over the body, and that can create a significant issue. Excess fluid in tissues for an extended period of time can cause cellulitis, where you have inflammation in and around the cells, which can then create additional swelling, which can split the skin, which can lead to even additional issues with infection. So an inflammatory response is a good thing, but there are times we need to keep the inflammation down. Sometimes we do that by taking steroids, right? We try to keep inflammation down by taking steroids. So you don't take steroids forever, because steroids on their own also have a significant problem with long-term use. One of them is making your bones very, very fragile. All right, so what are the signs of inflammation? You know that you have redness, heat, swelling, pain, and at times impairment of function. Let's say you got that fire ant sting on your finger, or fire ant bite on your finger. Then you would have swelling and redness and pain, and you would have difficulty moving that finger. So that would be impairment of function. So I just gave a minor example of what happens, but I think you can understand what would happen on a larger scale. So in this image, you see again a person being pricked by a pin. There are chemical alarm signals that are released by your body. Your blood vessels again dilate. The phagocytes come out because there's more space, but remember we also have fluid that comes out. And notice what happens. Here, the skin is not raised. Here, the skin is raised. So you have swelling and inflammation in that area. The phagocytes come in, take away all of the invaders, and you have this lowered swelling, right? So that shows that the inflammation has decreased. So let's look at how we have this non-specific defense and specific defense work together for having a complete immune response. What we've talked about so far is the non-specific defense, and here we have just a few examples. We have the complement system, natural killer cells, and macrophages. So we know that complement attacks by circulating proteins and essentially making holes in the microbes, but they destroy the invader. Natural killer cells and macrophages, you have direct physical and chemical attack on the invader. So essentially what you're getting here is destruction of the invader. And that's not the only thing that happens. With this non-specific defense, you also have presentation of the antigens. So those cells that come in, those invaders, have specific flags or antigens on their cells that your body will react to immediately, non-specifically, but then they can react to specifically in this specific defense, which is considered the immune response, right? And we're going to talk about this type of specific defense. And this is where we're going to talk about T cells and B cells and memory, and why we have different reactions when you're invaded sometimes by a virus again. All right, so this third line of defense is specific. The first two are non-specific, the third line is specific, and it's considered to be adaptive. It adapts to what the invader is. So what we know is it's specific. It recognizes a specific antigen, that is the flag on the outside of the invader, or thought to be invader. So let me put a little caveat on there, because sometimes your body attacks something that's not an invader. Sometimes it attacks your own cells, and that's called an autoimmune disease. So we'll talk a little more about that. With adaptive responses, there's also memory. So your body remembers that they saw that antigen before, and they've probably built up antibodies to it. And this is systemic. It goes through the entire body. So what we've talked about before is restricted to the initial infection site. Now, let's talk just for a minute. Let's say you had that fire ant, interaction with that fire ant, and you had a reaction at the site. Well, some people are hypersensitive to fire ants, and they might get a whole body response. That's a little different, right? And we'll talk about that hypersensitivity to something that should be just localized to the initial infection site. Let's look at this historically, and let's look at Dr. Edward Jenner. He is considered to be the father of immunology. And in 1796, he came up with vaccination, or the concept of vaccination. Okay. Now, what he did was sincerely unethical. However, and in no way can we make it right. However, because of what he did, he put things into motion that allowed us to understand immunology and vaccines to this day. All right. Just to be really clear about vaccines, I want you to look at the picture of these two boys. In 1900, they were in the same class at a school in Leicester, England. There was a classmate in their room who had early and undiagnosed smallpox. This young man received the vaccine and this young man did not. So if you question whether vaccines are effective or not, I just want you to look at this picture. My guess is this young boy probably went blind if he survived this, and he may have lost his hearing if it went into his ears, and truly he was scarred from one end of his body to the other, right? So let's talk about how Edward Jenner realized that vaccines are realize that we have the ability to keep people from getting disease as badly, if at all, right? It wasn't called vaccinations at that point. Okay, so how did he figure this out? You may have heard at some time that someone would refer to a young girl's skin and would say her skin is as fine as that of a Dairy Maid, right? Beautiful as a Dairy Maid, or has a beautiful farm girl's complexion. Well, where did that come from? In the 1700s and 1600s, smallpox was a big deal, and there was a reason why people used to powder their faces the way that they did, trying to hide smallpox scars, because even the rich got smallpox. However, Jenner noticed that Dairy Maids really didn't get smallpox, and if they did get it, they didn't get it as badly. So what he figured out is that the Dairy Maids were exposed to something called cowpox. That's the reason why we have the cow with the spots in it in this picture. And so because the Dairy Maids were exposed to cowpox, they had some form of resistance to smallpox. It could be complete resistance or just a small amount of resistance. So what he did, and I'm going to make a long story really short, is he actually got cells from people from the smallpox wounds, essentially pus, from individuals who had smallpox, and he inoculated, or exposed, I should say, the Dairy Maids directly to the smallpox, and he noted that they had either lesser forms of smallpox or they did not get it at all. While he exposed the Dairy Maids, he also exposed other people who did not come in contact with cows to smallpox at the same time. And so those people actually got smallpox. Quite unethical, no matter how you look at this. But because of that, he was able to describe very early how people were resistant to some disorders. Right. So with this image, you can see the amount of antibody that is produced by a person, and this was the exposure to cowpox, and this is the exposure to smallpox. And so this is what Jenner essentially said. The Dairy Maids have what is called a primary immunity because they had been exposed to cowpox. When he exposed them to smallpox, the amount of antibodies they produced was extreme because their cells recognized, their body recognized something about this that was familiar, and it allowed the dairymaids' bodies to mount this huge immune response, which essentially allowed them to not get smallpox or not get it as badly. It's because they had this primary immunity, then they were exposed to smallpox, and they built up this secondary immunity. So if they were exposed to smallpox a third time, they were golden. They wouldn't get anything. And so that's the reason why we were able to get, for those of us that were military brats like I was, and we traveled overseas, we all had the smallpox vaccine, but it's essentially been eradicated in North America. So if you just lived here, that was not part of your vaccination. But those of us of a certain age, and especially those of us who were children of military personnel, we all were vaccinated against smallpox. And what we had was we had a little scar on our shoulders where we were given a small amount of the killed or attenuated disease, essentially, and that allowed for us to build up antibodies so that if we're exposed to it, we won't get it. All right, so let's look at some different types of cells. Some of these we've already talked about. So this light purple is this innate or rapid response, the nonspecific, and we talked about macrophages, natural killer cells, eosinophils, complement. All right, then over here I told you we had the T and B cells. Well, there's a part in this Venn diagram where we have this overlap, where we have natural killer cells, but these are natural killer T cells versus just natural killer cells. And then we have the regular T cell, right? So we're going to talk about this slow response, this adaptive immunity. So let's talk a little bit more about antigens. So remember I said that antigens are the flags on the outside of a cell that allows for your body to recognize whether the cell that it is encountering is yours or is an invader, right? Again, we're talking about an adult who is in homeostasis. We're not going to talk about autoimmune diseases at this point. So an antigen is a molecule that provokes a specific immune response, right? So they reside on the outside of the cell. Each antigen has antigenic determining sites, right? So this is an antigen. So this would reside on the outside of your cell. And if it's a large enough antigen, if it's a complex one, it's going to have different binding sites. And so this is what you can see right here. And then we have the antigenic determinants that would bind to the specific sites, all right? Okay. Now let's talk about antibodies. Remember, when we think about that cowpox example, each one of the cowpox microbes had antigens on the outside of the cell. Well, your body, once it encountered those, built up antibodies or immunoglobulins in response to those antigens. And so you have antibodies that have built up because of the first exposure to the cowpox, right? Now, if you get a second exposure to cowpox, and in the example I gave you, it was smallpox, then your body's going to mount this even larger defense of antibodies. So what does an antibody or an immunoglobulin look like? I don't want you to get too wrapped up in this, but this is the general shape of an antibody. It looks like a Y, right? It's a protein. You have polypeptide chains. They are not going to destroy an antigen. They just tag it, and they tag it for destruction. So I don't want you to think that when we say an antibody interacts, that it's actually the attack of an antibody. It is truly the tagging. An antibody attaches to the antigen, and it forms an antibody antigen or an antigen antibody complex, and that marks the cell for death, right? And so it's other cells that will actually kill it. All right, so what do antibodies do? Once they've tagged it, how does the cell die? Well, one of the things that can happen is complement can jump in here again. And so it can expose what are called complement binding sites so that complement can bind it. And what did I tell you? The cell explodes. So complement can bind, and then the cell lyses or it explodes. You can actually also have neutralization of it. So you have antibodies that block the binding sites on a virus, for example. So that antibody antigen complex stops the virus from binding to a host cell. Sometimes you have this attachment and it allows for the invader to actually just precipitate out. Okay, so that's what we're seeing here, precipitation. So we can have this neutralization, so it masks the part of the virus or the bacterial exotoxin, and that's what you're seeing here. The Ys are attaching, and they're making it to where they can't attach anywhere. Sometimes we actually have what's called agglutination. These antibodies will come in, they attach to the invaders and then, or the infected cells, and they then will agglutinate. And again, that creates a problem. So if you have neutralization, agglutination, or precipitation, that can allow for phagocytosis because it's marked those cells in some way, and phagocytes will come in and destroy them. All right. Now, if complement attaches, one of the things, of course, is cell lysis. The other thing that can happen is that it creates inflammation, which creates chemotaxis, and then they will be destroyed. Okay, so antibodies, again, let me just be very clear, the antibody itself does not kill, right? It marks it for death. Okay, again, I don't want you to get hung up on these shapes. I'm putting them here so that you can actually see that they are different. But what I want you to understand is what these different immunoglobulins do, right? How do they act? And remember, these are globulins, right? Albumin, globulins, fibrinogens. We're looking at all of these plasma proteins. Well, we're digging deeper into the plasma proteins. All right, so IgD has a very specific job of attaching to B cells, right? And we're going to talk more about B cells in just a minute. It doesn't mean a whole lot to you right now, but just know that they are the receptors for antigens of B cells. I'm going to skip IgM and IgG right now. We'll go to IgA, and this prevents attachment to body surfaces. IgE, and remember, whenever you hear E's, think about what we know about eosinophils. It causes an allergic reaction, right? It causes the release of histamines by attaching to mast cells and basophils. So when you have a lot of IgEs, remember what we've talked about, you're either having significant release of histamine due to allergies, or one more time, if you have a high number of IgEs, it could be because you have a high number of parasites. Now let's go back up to IgM and IgG. All right, this is what I want you to remember about IgM. When you see the I and the M, I want you to think immediate. And I want you to think that IgG is related to IgM, but it is later, right? So IgM is released during a primary response. It means you have a current infection. IgG means you've been exposed to something a second time and that you've had a past infection. So let me give you an example. In 2012, I had a pretty severe case of West Nile. And there are a lot of people that did. I was case number 123 for Denton County. It was life-changing for me, but it was also a great primer in immunology for both me and my husband. I mean, we've taught about IgM and IgGs for years, but this really brought it home. So at that time, in August of 2012, there was only one place in the United States that actually did testing for West Nile. By the time August was over, there were at least 4 places in the United States that tested for West Nile because so many people were sick with West Nile that year. The first test I had was negative, but then I had a second test 5 days later, and it was the highest positive that had been seen by many. I had just a high number of IgMs. So when I get tested for West Nile now, I now have IgGs. My IgMs are low because it's not going to be my primary response. I do not have a current infection. It was 8 years ago. But when I'm tested now, my IgGs will be higher, okay? So IgM and IgGs go together. IgM is primary, IgG is secondary. All right, so if you look at that primary and secondary figure when I had the cowpox and the smallpox, that's essentially what you're going to be looking at if you're looking at immunoglobulins. Again, we have this memory, right, that we've had some exposure, and then when we have another exposure, your body mounts this huge response to it. So again, on this axis, we're looking at the number of antibodies that a person has. All right. Now on this axis, we're looking at time in the number of days. So at day 0, let's say I was bitten by the mosquito. I had maybe day 5, I had my primary response to whatever that mosquito, that the virus that the mosquito injected in me that had the antigens on the outside. This is my response to those antigens, right? Then it's not exactly true for West Nile that it's only going to take 28 days. However, let's say that it is. So 3 weeks later, I get another exposure to West Nile. My body is going to fight so hard against West Nile that it mounts this immune response to that antigen. But let's say at the same time, I also get exposed to another virus. Again, I'm going to have this primary immune response, and we could continue this, okay? So that's this immunological memory. I've mentioned lymphocytes a few times, and remember we talked about lymphocytes when we talked about blood cells. So when we talked about lymphocytes earlier, I just lumped them into a category, just called them lymphocytes. And then I mentioned to you that we have T and B lymphocytes. So they're called T cells or B cells. We don't often say T cell lymphocytes or B cell lymphocytes. They're either just T cells or B cells. And the reason why they're called T cells or B cells, it depends on where they become mature or immunocompetent. B cells mature in the bone, T cells mature in your thymus, right? Your thymus is a gland behind your sternum, and as you get bigger, it does not, but it still is able to do its job. It will start to shrink when you become elderly. So there's a few different types of T cells. There's an inducer T. It oversees all of the development. There are helper Ts. Sometimes they're called CD4s. They start the immune response. Then we have cytotoxic Ts. They're called the CD8s. And they are just that. They're cell toxic cell killers. They lyse the infected cells. And then we have suppressor Ts, and suppressor Ts stop the response. So inducers, helpers, cytotoxics, and suppressors. So your B cells recognize what's native to you, and your T cells recognize what's been processed. And so what exactly does that mean? All right, so all of your lymphocytes are going to come from your bone marrow. Now, your B cells are going to become mature or immunocompetent within your bone marrow, and your T cells are going to circulate in your blood, end up in your thymus, and become competent there. They're still considered to be naive because they've not been exposed to anything, right? They're naive immunocompetent cells. Both T's and B's will make their way to your lymph nodes and your spleen and other lymphoid tissues. Once they make it there, they leave the thymus or the bone marrow and they make their way to these lymphoid tissues. This is where they become challenged by antigens. And so once they've been challenged by an antigen, they become activated and immunocompetent. And when they become immunocompetent, they circulate in your blood and lymph, right? They circulate continuously throughout your body, right? So we're going to look at the two different types of immunities. B cells are the stars of humoral, and T cells are the stars of cell-mediated. But that doesn't mean they're the only players, right? So let's look at humoral first. And I defined humors for you earlier. Remember, humors were considered to be way back many years ago, considered to be the fluids in the body. And so if something is said to be humoral, it means it travels the whole body. And this is an antibody-mediated immunity, right? Antibody-mediated immunity. So it takes both T cells and B cells for this to occur. And these antibodies are constantly circulating through your humors. They are inactive, and their job is to mark invaders for destruction. They don't destroy, they mark them, right? So this is antibody mediated. So what do they mark them with? They mark them with antibodies. Cell mediated it means the same as cellular immunity, and it involves only T cells, okay? Only T cells. So you have a direct attack of cells, right? A direct attack of cells, or you can create a cascade that allows for inflammation, chemotaxis to occur, and so that other white blood cells are activated and will attack. All right, so here's my question to you. If you have lymphoma, you can have T or B cell lymphoma. Which one do you want to have? If you gotta have one, which one do you want to have? Think about this for just a minute. Do you want T cell or do you want B cell? Well, the answer is you want B cell, right? Well, you don't want any of them, but you want B cell. B cells are only active in humoral immunity. T cells are active in both. If you have T cell lymphoma, that means both forms of immunity are going to be compromised, right? I had a German short-haired pointer that was a rescue, Gracie. She was the most beautiful, she was huge, a big, big German short-haired pointer. I think she was mixed with a hound. And one fall, the fall of 2013, I noticed she really wasn't eating and she had a bit of lethargy. And I mentioned it to my husband, and I had to go out of town for something, and he took her to the vet. And they did some quick tests in the office and realized her calcium was high. Well, both my husband and I know that when you have calcium that is high, excessively high like she had, we knew it wasn't good. Had a lot of testing done, took her to a doggy oncologist, did everything that we could, and they said, well, she has lymphoma, you know, and regardless of what type it is, you know, it's not going to end up well. But if it's B cell, then she can live a little longer. And so we actually had further testing done, and it was T cell. And she died in February, the following February of 14. So it was, again, another first person experience of, you know, we know the immune system, but how well did we know it? And this was a way for us to truly, truly understand why we'd always said, well, it's better if you have B cell. And there's really nothing you can do when my pup, for example, had T cell because her entire immune system was compromised at this point. All right, another concept we need to talk about is major histocompatibility proteins, all right? So this is the major histocompatibility complex, and it's made up of proteins. These are what mark your cells as self. All right, in this image you see MHC1 and MHC2. Just know that those are major histocompatibility proteins. So it marks your cell as yours. So you have different MHCs than I do. And so these can act as triggers to an immune system. And of course, this is incredibly important in tissue transplants. That's why your immune system is suppressed and you'll be on immunosuppressant drugs for the rest of your life in order to keep your body from rejecting the transplanted organ. All right, so let's just look pictorially at what happens with T cell immune defense. All right, so these little red guys, these are viruses. So a virus invades your body, and macrophages start attacking, which is great. And not only that, but you actually have cells that have been invaded by the viruses. That part's not so good. But these two hopefully are going on simultaneously. So your macrophages ingest the cell, take it apart, and then they present part of that virus on their antigen. So this purple thing is the antigen of the macrophage. So what it does is it takes this process piece and presents it here, and presents it here, and presents it here. So this is a processed viral antigen. It's been taken apart. It's not useful, can't be used for anything, but it does allow for your macrophage to start this immune process. So once your macrophage has taken apart that virus, it will produce interleukin-1, right? Interleukin-1 interacts with helper T cells that are have interacted with the macrophage, right? So we have interleukin-1 and the helper T cell. That then allows the helper T cell to make interleukin-2, right? Now let's just stop right there and go to your cell, your just regular, maybe it's a liver cell, that's been infected by the virus. When that occurs, your major histocompatibility complex protein, again, you have one here with the macrophage, now you have one here with your liver cell, for example, it's going to process the viral antigen. But what you notice here is the virus stays together in your liver cell, but it's destroyed in your macrophage cell, right? So this means you have a straight up infected cell. So it presents the viral antigen, okay? Well, because it's presented this viral antigen, your cytotoxic T cells will attack. And that's what's occurring right here. Cytotoxic T cell has attacked. Well, once the cytotoxic T attacks and we have the presence of interleukin-1, it allows for the proliferation or the synthesis of more cytotoxic Ts. So you're now making more cytotoxic Ts that are going to be present to destroy more infected cells. And that's what you're seeing down here. The infected cell is destroyed by the cytotoxic Ts. So with this example, what you're seeing is the T cell directly attacks and destroys the infected cell, right? But it took a helper T cell in order for this to happen, and it took a cytotoxic T cell for this to happen. Also, you see that we had a macrophage, and the macrophage destroyed the virus, which is great, but you also had infected cells. So if you're immunocompromised and maybe you don't have enough macrophages and maybe you're low on cytotoxic Ts and helper Ts, you're just low on Ts period, you can see how that virally infected cell could make more virally infected cells and more virally infected cells, or the virus, excuse me, I should say the virus could go on and infect more and more and more of your cells. All right. That's the T cell immune defense. So how do we start this? We've already gone over the picture, but you see that macrophages are constantly inspecting cells to make sure that they have the correct major histocompatibility complex proteins. So T cells, as you can see here, here's the helper T cell, is going to bind to antigens presented to them on the surface of a cell. And that's what you're seeing right here, right? With the macrophages, the virus is taken in, it's partially digested, and then it's presented, right? That's an antigen presenting cell. So if you have a macrophage that encounters a pathogen that doesn't have a cell that MHC that it recognizes, it is going to secrete this alarm signal, which is interleukin-1. There's interleukin-1 right there. That stimulates the helper Ts. Once the helper Ts come in, it initiates the response of the other Ts. That's what you're seeing right here, right? The cytotoxic Ts. And it's also going to stimulate the response of the B cells. We're not seeing this here. We're just seeing the action of the cytotoxic Ts in this image. All right. So the helper T cells, they become activated because they bound right here. They secrete interleukin-2. That stimulates the production of cytotoxic Ts. And if you have cytotoxic Ts that fit this antigen, MHC protein complex that you see right here, they begin to multiply rapidly. That's what you're seeing here and here. And then the virus laden cell is going to be destroyed, or cells are going to be destroyed. All right. B cells are a little different. All right, so in this example, we have this invading microbe, and it is covered with antigens. And so the antigens are picked up by the macrophage in this B cell immune response. And again, the same thing happens. You have the presentation of the antigens from the microbe on the macrophage. Interleukin-1 is produced, which stimulates the helper T cells, which then attach, and the helper T cells are going to, there's the helper T, and we're going to stop right here. They are still going to produce interleukin-2, but it's a little bit different when we're talking about B cell defense. So initially, not only did the antigens become phagocytized by the macrophage, but the antigens interact with your B cells. And when this happens, your B cells begin to present the antigens. And you can see that we have a processed antigen that has been presented. Once the B cells start presenting the antigen, and that's what we're seeing right here, the helper T cell then interacts with the B cell. So you have the direct interaction of the T cell and the B cell. When that happens, interleukin-2 is produced. When interleukin-2 is produced, you have plasma cells that are going to begin producing antibodies, and those are these Y-shaped structures right here. The antibodies then attach to the invading microbe, and it marks them for destruction, right? That's one thing that happens. Another thing that happens is these plasma cells will become memory cells that your body will call into play again whenever this invading microbe with the same or close to the same antigens come in. All right, so that was an overview. You have B cells that recognize the invading microbe, right? And they mark the pathogen for destruction. So this is the marking for destruction. You can have the antigen particles that enter the B cells. They're getting processed right here. Helper T cells that recognize that specific antigen are going to bind to the complex, and they stimulate the B cells to divide, and that's what you're seeing right here. All right, so we have these memory cells. So let's just look. Here's the antigens, and the antigens bind to the receptors on the B lymphocytes. These B lymphocytes will begin to proliferate, and they form what are called clones. So you have memory cells, remember on the former slide, and then you have plasma cells. And these plasma cells are going to attach to the cell so that it can be destroyed. The memory cells are there so that if there is a subsequent challenge or another exposure by the same antigen, then you're going to have these memory cells that are going to clone the cells identical to those ancestral cells, and they are going to make plasma cells that are going to secrete the antibodies that are going to mark those new invaders for destruction. And then you're also going to make memory cells. Okay, memory cells live a long time. Plasma cells' job is to secrete antibodies. All right, so here in this image, we have both the T cell and the B cell completely shown together in this image. And this is what happens when we have a virus, right? So here we have our virus, the red six-sided shapes. They infect a cell. And so they infect the cell, and the virus is presented, the viral proteins are presented on the surface. All right, so when that happens, the virus and the viral proteins are going to stimulate macrophages, and that's what you're seeing. Oops, sorry, nope. That's what you're seeing right here. Here is the macrophage that's been stimulated. And the same thing happens again. So you have these stimulated macrophages that are going to digest the cell, and they're going to present part of the virus on their major histocompatibility complex proteins. When that happens, we are going to produce interleukin-1. And when interleukin-1 is produced by the macrophage, it stimulates the helper T cell, right? When the helper T cell is stimulated, it's going to produce interleukin-2, right? So interleukin-2 has the job of activating both the B cells, that you can see here, and the cytotoxic T cells, right? When the cytotoxic T cells are activated, remember, it's an immediate response. It acts right on the infected cell, and it binds to them and it kills them. However, the infected B cells are going to multiply. Some B cells become memory cells. Other B cells become these factories that produce antibodies. And when they produce these antibodies, they bind to the infected cells. And that's what you're seeing here. When they bind to the infected cells, the macrophages are going to destroy those cells, and then the molecules are going to be tagged with antibodies, and we start this all over again, right? So for immunology, for this section, this is the process that you need to know. All right, so we've looked at innate and acquired immunity. Now let's look at acquired immunity and we looked at innate and adaptive immunity. I now want you to think about how we can acquire an immunity. And we talked about this earlier, right? We talked about vaccines. So with this acquired immunity, you can either acquire it naturally or artificially. And let's look at naturally. Actively, if you've been infected with something, you've had contact with a pathogen. So I should, we think, have immunity to West Nile. I had an active infection. I had a contact with the pathogen, and so I should, we hope, have enough antibodies. Passive, naturally acquired immunity is when you have antibodies that are passed from the mom to the baby. It can either be through the placenta or in her milk. It is said that a baby will have mom's immunities for 6 months to a year or so. Then we can get artificially acquired immunity. And so if we have the vaccine of a dead or attenuated pathogen, remember I told you I had a smallpox vaccine, or you can get artificially acquired passive. And so that's what people are trying to do now with the coronavirus. If someone's already had it, they're trying to, they're getting their plasma and then getting serum and hopefully injecting that into people so that they can have a passive immunity. All right, so what happens when a person is not in homeostasis? They can have something called SCID. These are severe combined immunodeficiency syndromes. Oftentimes a person is born with them. That is what congenital means, present at birth. Another form of homeostatic imbalance is autoimmune diseases. For whatever reason, the majority of autoimmune diseases, not all of them, tend to be more prevalent in women. Type 1 diabetes is autoimmune. Your pancreatic beta cells are destroyed because your body is attacking the beta cells of your pancreas. Remember, these are the insulin producing cells. Type 1 diabetes is completely different from type 2 diabetes. With type 2 diabetes, you become unreactive to your own insulin, right? Type 1 diabetes, you can't produce your own insulin. I am a type 1 diabetic. That occurred late in life for me, and it is thought to be because I had such a severe case of West Nile virus. I actually have 3 autoimmune diseases now that I did not have prior to having West Nile. So let's just pause right here and let's talk about coronavirus for just a minute. There are people who are still saying, and please remember that this is recorded in summer of 2020. You may be listening to this in fall of 2020 or later, but there are people that are still saying, if you get it, you'll be fine, you're going to be immune to it. Well, that's just it. We don't know what happens to a person after they have coronavirus and they, I'm doing air quotes here, recover from it. I had West Nile and I, air quote, recovered from it, but I really didn't. Y'all, there's something called post-polio syndrome. People had polio, tons of people had polio in the 50s. And so if they lived through it, then they were thought to be okay. Well, no, they're really not. There is a tremendous amount of the virus that actually affected the spinal cord and made people compromised with mobility. There are many people that have compromised respiratory systems. So polio was not just one and done. West Nile is not just one and done. And it appears that the coronavirus is not just one and done. There is information coming out now where there will be significant vascular issues, significant respiratory issues, and now there is some reports that there are nervous system issues due to this. And I forgot to mention this part from West Nile virus. I actually have permanent nervous system damage to the vestibular cochlear nerve in my right ear. The vestibular portion is essentially gone, and it was there prior. So I have balance issues, and this is all because of West Nile. So I want you to really, really don't be afraid, but be educated. So whenever you hear somebody talk about, oh, it's just a virus, you'll be fine. Have you ever had shingles? Well, yeah, chickenpox is just a virus until you have shingles, because that's how it pops up later. So viruses are like cockroaches and Twinkies. They're going to be here when everybody else is gone. All right, multiple sclerosis is also an autoimmune disease. We talked about that with the nervous system. Myasthenia gravis, there is impaired communication between the nervous system and the muscles. Lupus, there is many different types of lupus. It's a disease of skin and the internal organs and lungs, and oftentimes lupus occurs with other autoimmune diseases. And rheumatoid arthritis is another type of autoimmune disease. And this is where your body no longer recognizes your flags on the outside of your cells, and so your body begins to attack. Then there are acquired immunodeficiency syndromes such as Hodgkin's disease, HIV, and AIDS, right? So these are acquired. Nobody knows exactly how to, there is no cure for these, but you can acquire them from another, for HIV, AIDS, you can acquire from another person. All right, so let's talk about allergies or hypersensitivities. So these are adaptive defenses, and we're looking at humoral immunity. So in this very first image, let's just say that this is, I don't know, pollen. Let's call it pollen. You have some allergen that invades your body, and it's got a specific antigen. Your plasma cells are going to produce lots of IgE antibodies against it. And when that happens, these antibodies are going to attach to mast cells in your body tissues and to circulating basophils. Those mast cells that have these IgE immunoglobulin antibodies that are attached are going to be also reactive with histamines and other basophils. So that's your first response, right? Then when you have a secondary exposure to it, you have more of that same antigen that invades your body. That antigen is going to combine with those mast cells that have the IgEs attached, and that's going to trigger this degranulation of all of these histamines, right? So you release all of these histamines. These histamines cause your blood vessels to dilate and become leaky. We've already talked about that. So fluid leaks out, you get edema, which is that fluid gathering in your skin. You may have large amounts of mucus that are produced. Your smooth muscles may begin to contract. Think about an asthma type situation if you look down here at bronchioles, right? So this is a typical respiratory effect of an allergen. But some of you may have allergens to food, and you don't have a respiratory type reaction. You may totally have a digestive reaction where you have diarrhea and vomiting. There's still a lot of release of mucus, but your body just reacts to it in a different way. Another point I want to make with this is I want you to understand it's never your first exposure. It may be the first exposure you're aware of, but it can never be the first exposure. It has to be a second or third or fourth exposure. It could be your 10th exposure. Let's say, for an example, it's a honeybee sting. You're stung by a bee and you don't have a very bad exposure. And then, every year for 10 years, you're stung by bees and your reaction never gets bad. And then on that 11th sting, you go into anaphylaxis. That's just your body with that buildup of mast cells and IgE, and it hit a trigger, and you had a huge reaction to that. So, you may have eaten strawberries all your life, and then all of a sudden you eat a strawberry, and your mouth feels tingly, and you get a rash on your face, and you begin to itch all over. It's just hypersensitivities are very, very odd, and they don't all ever act the same way. But what we do know is it is never the primary exposure. It has to be the secondary or after exposure in order for you to have a response. Here's another example. You have an antigen presenting cell, that's the APC. It processes the antigen and it presents it. And there you are. You have it presented, and you have a helper T cell that is going to interact with a B cell that is going to, then the B cells are going to proliferate, and you have all of these memory cells, and they're going to secrete, they differentiate into these plasma cells, and they synthesize and they secrete these IgE antibodies. IgE binds to these mast cells. So it's this combination of mast cells and IgEs that, because the mast cells release all of those inflammatory molecules, right, histamine, that allows for you to have those allergy symptoms. So there are different types of hypersensitivities, and I am not going to go through this and ask you to explain to me the different types. I just thought it would be helpful for you to see what type of reactions that a person could have. So let's just start with the different reactive. So IgEs, that's what we've been talking, right? So this is anaphylaxis. It could be local or systemic, hay fever, food allergies, and drug allergies. That's where you get the E immunoglobulin. IgGs and IgMs are part of type 2, and this could mean that you've had a blood transfusion and it was mismatched, or this is hemolytic disease of the newborn, or erythroblastosis fetalis. And this is where you get this just stimulation of your immune system to include natural killer cells and macrophages and neutrophils, complement, cell lysis. All of these things come together and can create that type of hypersensitivity. If it's type 3, it's also IgG and IgM. And this is the way that we know that it is an immune system response that causes, for example, lupus and rheumatoid arthritis. This is, again, IgGs and IgMs, right? And then there's what's called the type 4, and this is with T cells. So type 1 diabetes, which is what I have, and multiple sclerosis, and the cytotoxic T cells just attacked my beta cells and took them out. And it did it very quickly. I was not diabetic, and then all of a sudden I was, and it happened within months for that to occur. So, but it can also be something as simple as contact dermatitis, which is poison ivy, right? Or if you are allergic to poison oak or poison ivy, or if you're allergic to a soap, perhaps, that's contact dermatitis. So this means that you have helper T cells that activate both macrophages and cytotoxic Ts. Please don't think I'm going to go through, you're not going to have to give this back to me. I just want you to see the different types, right? Remember the process you have to learn, which is how T cells and B cells interact together. Okay, and this is a fabulous time in the time of COVID-19 to talk about antigen shifting and antigen drifting. Let's talk about shift first. With antigen shifts, either the virus or the bacteria or whatever the pathogen is, it's just easier to talk about viruses, they mutate so quickly that the surface antigens become so different that by the time your body has made a significant number of antibodies to the virus, it's changed so much that your body can't recognize it anymore. So it survives the attack. A great way to think about this is if you think about the flu vaccine. You know that every year you get a different flu vaccine. And that is because antigen shifting occurs with influenza. So the different health organizations in the world have the ability, and they try very hard, to make a prediction of which type of flu is going to be the most prevalent one in the coming year. And then they make the flu vaccine to match that flu, the one that is their best suggestion for what it is, because of the antigen shifting. Okay, so it's not always right. And it's still better to get the flu vaccine than it is to not get the flu vaccine. But we are going to have shifts. All right. Drift, antigen drifting, means that you have these viruses that have genetic mutations in the virus, and it makes it difficult for anybody else or your body to, again, recognize the new virus. It started out as virus A, but now it's virus B because it has drifted over time into a different virus.